It is a distinct privilege and honor to introduce our Dr. Shepherd from NYU. I found out from this whole visit that we both went to medical school at the University of Florida, go Gators. He had gotten his MD and PhD from University of Florida, his residency and DSF, and has been faculty at NYU. Currently an associate professor of radiology, and the director of PET-MRI. And so please help me welcome Dr. Shepherd to our grant round.
Great, thank you. Can everybody hear me like in the back of the room? It's just I can see the microphone. Okay, cool. So I just want to thank Karen for coming and give these talks. I always really love talking about so it's always a lot of fun to give these talks at University of Utah. It's always been a place that I didn't train here, but I always know how great the education is here, and there's a lot of residents and fellows in the audience. Like I said this morning, the StatDX webpage got me through the first 2 years as an attending for all the findings that I didn't understand or know as well as I thought. So what I'm going to talk to you about today is something that I actually did not train in as a resident fellow, but started doing as a faculty member at NYU, talking about integrated PET-MRI. And I hope to show you its potential in the next decade or so to really change neuroradiology in particular, but I think will have impact on other specialties in radiology. I do have some disclosures. I'm not going to talk about the startup in any way. We are very Siemens heavy site, so most of the images you're going to see are from Siemens scanner, but other vendors also have PET-MRI. And when I finished my fellowship, Sumi Cha and Christine Glastonbury took me aside, and I realized there's probably only 5 people in the audience even know this movie, which is probably one of the 10 best movies of all time in the United States. But in this movie, this guy takes this actor, Dustin Hoffman, aside and says, you know, plastics is the future, right? It's 1967. When I was finishing fellowship at University of California, San Francisco, Sumi and Christine said, PET-MRI is your future. And I was like, what are you talking about? I don't know what this is. I'm not going to show slides of the technology, but just the only thing you really have to understand about it is that the combination of a PET detector and an MRI scan. So we're really going to focus on the imaging and the clinical functions of that technology. And I think a lot of people still have this question about whether this scanner really has any true value and if it really could just be replaced by a PET-CT and an MRI scan. And I'm not sure that I fully answer that question, but I hope to sort of show you some of what I think are the answers to that. And I'll start with this example of why you might care about. And so here was a case. I do the Epilepsy conference every week at NYU. It's very well known, 7 in the Northeast United States. And I'll just let you look for a minute. Does anybody see a finding? Slide before, but cheap. And as Karen now knows, I drink a lot of coffee, and I thought I saw very subtle gray white blurring in the right superior frontal sulcus cortex. And then when I looked very carefully and ended there pretty harshly, if you will, I thought I saw a transmantle sign. And this epilepsy center is very well known. It went well, this is the thing, talking about anything with them allowed. Hey, this is me like 1 year out fellowship at UCSF. Some kind of finding people to throw tomatoes at you and make you off the stage, right? And it is a pretty subtle call. But here what we see is the blended FDG PET-MRI image on the left, and then on the right, the coronal of the PET. When we were doing dual reads, the PET was actually initially read as negative. I said, no, go back and look at this one area. And I hope that we can appreciate that left superior frontal sulcus cortex is not taking up FDG. And so this is an extremely subtle finding that would be hard to see on just reading a PET directed from the MR. This is the intracranial EEG study that was done subsequently, and I still fall asleep when they show me these in conference. But what the red arrow is showing you is a seizure coming right from the Dept electrode placed in the MR. And so this patient actually went on to have resection. They actually resected the FDG abnormality, which you may recall was larger than the and Last time I checked, it was type 2 focal cortical dysplasia. He was 8 and has been seizure-free for the last decade. So we basically, as a team, we sort of cured this patient of seizure disorder. Now, he also was front-loaded the process. This really was sort of a poster child of the potential value in epilepsy. And so just to come back and sort of talk about my objective for the next 40 minutes or so, we're going to talk about epilepsy and dementia a lot, just because those are kind of my areas. Those would be areas that we're using our PET-MRI for the most. But there are some other applications that I'll touch on at the end. And I'll sort of allude to what I think are the very near future applications at NYU and other institutions as well, particularly in neuroradiology. I'm going to show you just something, a couple slides that chairs and administrators like about how we've been using our scanner. Interesting. And then I'm going to show you a few more cases, particular residents. It would be nice to just see some of the less common things. But the point here in this sort of second round of cases is really to show you the sort of value, the lessons that we're learning from using PET-MRI, looking at it as a single reader, and what you learn from that. And then I'm going to show you just two kind of cool applications of PET-MRI at NYU. We'll see. And then we'll sort of talk briefly and go from here. And I realize trying to show that it's okay, but this is very neuro-heavy talk. But most of the findings that I'm going to show you would be helpful for residents and fellows. And I think if you are a body imager, there are things to learn here, particularly if you don't care about the images, you won't be distracted by it. But I think there are lessons to be learned here for many other fields as well. We just happen to be a very neuro-heavy site. We'll start with epilepsy. And again, I just for a basic review, remember that the workhorse in PET-MRI is FDG, where we replace this 2-hydroxy position with this F18 that emits positrons that can be detected with a PET detector ring. And when the glucose gets phosphorylated, it gets trapped in the cytosol, and it generally stays there for the next 6 to 8 hours as it decays. And that's really what we're looking at when we use FDG PET on the brain. And there are actually 3 reasons that we see decreased FDG uptake. So a lot of people think it's all just due to hypometabolism, but it actually can be due to neuronal or synaptic loss. It can be due to changes in metabolism that could be due to homolog, cerebellar dysgenesis. And then you can also just get it as the FDG is effectively like a stain. That is, the amount of FDG that shows up is basically determined by perfusion. So we're not really going to talk about the nuances of which one is the dominant effect. But these are all 3 sort of happening at the same time. Part of the reason that PET is actually much better at showing dementia than MR. And we'll come back to that. For epilepsy, again, just a brief review, just so you can understand what I'm going to show you in a minute. Very helpful G to be used in patients that the EEG doesn't show anything, the MR doesn't show anything. The MR or the EEG shows too much. So sometimes you'll see 5 different findings. You don't really know which one is the one that is the sort of source or culprit of the seizures. And then the last one, which I already sort of showed you a brief example of, is the extent of FDG abnormality actually is very good at predicting the prognosis, particularly when you're considering surgery. So if someone has MTS and very focal FDG abnormalities, they are likely to do very well in resection. They're as effective, they're less likely to be seizure-free. And sensitivity is really detailed, but particularly for adults with long-standing seizures, and this has been my experience as well, the PET is rarely negative. How many times do you read an MR for seizures where you see findings? PET is almost always positive if you know what you're doing and you look at places. So it is very helpful. Noriko Salomon and others at UCLA showed years ago that combining MR and PET, these were separately acquired, not on an integrated PET-MRI, can be helpful for finding subtle abnormalities. Here, a dysplasia, if you will, in the left perirolandic region, the FDG helps locate it. This one on the right is a little bit more subtle, but again, a subtle dysplasia that was located more based on the FDG overlay than the MR itself. And she showed that the sensitivity went up for focal dysplasias in these where they were combined reads. So they were sort of acquiring a PET, acquiring an MR, and then looking at them together. So we sort of did the same thing, except now we're doing it all at once. And we'll talk about why that may have practical benefits. Here, a really great example of how I can save your butt, right? So what we see here for the residents is a classic example of sclerosis on the right. So we see hippocampal atrophy, layer hyperintensity, and loss of structure. Particularly outside of academic medical centers, when you see a right mesial temporal sclerosis, most people are just going to resect that. It's most likely left language dominant. They might confirm that, but then they're just going to take the temporal lobe. And these are the kind of cases we see at NYU sometimes where parts of the brain are already missing because this is sometimes the source of failed epilepsy surgery. And so again, the MR findings are great for the right side. When you first look at this FTG pattern in creating brain, we also see supported on the side ipsilateral from the MR. The other side is also abnormal. And so this PET basically shied us away from rushing to a right temporal lobectomy. We subsequently put RNS on both sides, and then we demonstrated over the next 6 months the patient was having seizures from both sides. So the PET basically prevented this patient from having a non-healthcare, non-conclusive right temporal lobectomy. So again, I think it's a really great example of the value of PET. The surface maps are okay, but again, I think it's better to look at the 3D as we'll see in other examples as well. Here's another example, very humbling for a neuroradiologist to look at MRI. And this case has a really classic story for left temporal lobe epilepsy. The clue might have been that what the semiology or aura was that they started hearing sounds like they described it as like Chinese men talking. So they had an auditory aura. And the EG was not for medial temporal lobe epilepsy. And again, the MR was completely normal, maybe just a touch of anterior hippocampal atrophy, but the FTG was clearly abnormal on the left side. What we see often in our cases is that lateral temporal lobe epilepsy is very rarely MR positive, but almost always has an FTG appearance like we're seeing here. So again, a very humbling experience. And I often tell my fellows when I train them to read integrated PET-MRI that you are going to get to this place by January of your fellowship year, where you realize that all these MR findings that we high-five each other for aren't as helpful as you think for epilepsy. And a lot of times we are lucky to see the tip of the iceberg seizure network that is truly there. So again, a very interesting experience as a neuroradiologist. This is a very detailed slide. I'm just going to show you all the text, but what I want to tell you is that in an initial review with Joanne Rispoli, who's now faculty at Boston Children's, we looked at like the first 400 cases that got PET-MRI for epilepsy. And what we saw was that about 200 of them had had a prior MRI. Half of them basically were read as normal. And in those people that were read as MR negative, actually 2/3 of them had a finding that led to further management. So it actually is a remarkable change in how we deal with epilepsy patients at NYU. So essentially, if you are 10 or older at NYU and you are considering surgery, you'll almost always get PET-MRI before surgery. And part of that is also because once you start resecting things, the FDG isn't as helpful. So you can't do it after the fact and get the same kind of information. If you're a girl, we'll go down to 6, 7, or 8, because sometimes they'll hold still. Boys, not so much. But anyway, it's turned out to be a real game changer for us at the Epilepsy Center. And for us, just locally, this was really our first champions clinically. We really started doing a lot of epilepsy PET-MRI first. And eventually, we sort of opened the floodgates for dementia. So I'll show you that now. And I always love showing this slide because it's from where I trained. And it's probably right after I left or when I was there. 2009, I was actually there, so I might be one of the guilty people here. But what they did, this is a group of neurologists who looked at patients with classic, what you may know as Pick's disease or frontotemporal lobar dementia. And all of these patients had very clear atrophy patterns consistent with the clinical diagnosis. And what they found was that only 10% of these patients in the radiology report was that diagnosis suggested in the report. And when they look at the reports, and I'll highlight here for you, I apologize for all the text, they found that actually the radiologist would often describe the atrophy pattern, but then do nothing with it. And when they asked, I think it was Chris and Bill Dillon, go back and look at it, they all could recognize it very easily when they were given sort of, this is a dementia case, what do you see? And so I do this, of course, just to pick on UCSF a little bit, but I really value my training there. But the take I get from this is that in general, radiologists are super uncomfortable describing dementia patterns or suggesting dementia diagnoses. And people say, oh, well, imaging isn't diagnostic. I agree, but a lot of times the imaging will suggest the diagnosis or trigger a workup that will lead to the diagnosis. And so the problem is that MR and CT are not particularly specific, and I'll show you that now. Just quickly, the guidelines for using FDG currently, 6 months or longer cognitive decline seen by somebody who knows what they're doing in neurology, unclear etiology. And so again, I showed this morning that this is a schematic conceptually of a patient who develops Alzheimer's disease moving from earlier age points on the left to full-blown dementia on the right. And the red is the accumulation of amyloid. Blue is the atrophy pattern that I'll show you in a second. Again, if you've had a lot of coffee and you're sort of really looking for it, you might catch it here. But the beauty of PET-MRI, depending on the tracer you use, whether it's tau, amyloid, or FDG, is you have a chance at seeing these people 10, 15 years before they become symptomatic or lose that brain volume. And so again, I think it's a very powerful technology. Here, just an example of what I would consider very classic imaging findings of hippocampal volumes. And for me, this is more maybe for the trainees, but I really love the axial flare. And what I'm looking for is I like to see the temporal horn and the entire temporal horn in a single image. The lateral margin is smooth, and a lot of times the flare gets a little bit brighter in the hippocampus. So those are kind of the things that I'm looking for. You can obviously use the Shelton scale, you can use volumetrics, etc. I just do it based on gut, but I see in a lot of cases. The problem is hippocampal atrophy is not particularly specific. And so here what we're looking at are 5 patients or subjects who have clear diagnoses of what we can call neurodegenerative disease. And one of them is a healthy control. And I would challenge you, some of you may get it right just because there's a lot of people in the audience, but 5 of these 6 patients have hippocampal atrophy. You may argue that 4 isn't too bad, but it's abnormal as well. But maybe number 3 doesn't look too bad, right? But the other 5 all have hippocampal atrophy. So the other lesson that you learn when you read PET all the time is that hippocampal atrophy, like hippocampal sclerosis, may not be as specific or celebratory in a sense as we thought. And so what we're seeing here is actually FTD, Alzheimer's disease, healthy control, vascular cognitive impairment, Lewy body, and MPH. So hippocampal atrophy is a great first finding to suggest that you may need to work somebody up. And I know Karen's seen this before, but you'll see this in the ED with head CTs. Just recognizing hippocampal atrophy in somebody who fell might be the thing that helps them get worked up 5 years before they finally get evaluated. So what's helpful is actually do the FDG PET. And so here what we're seeing are surface maps. Hopefully you kind of figure it out. But we're looking at on the upper left side, right side. We're looking above, below, frontal poles, occipital poles, and then the 2 mesial surfaces. The purple and blue are statistically different than controls. So what we're seeing are z-scores of 2 and 3 different than a group of controls. I don't actually love z-scores, but this is just a great image, so I kept it. But what we see here in that first patient I showed you with hippocampal atrophy is confluent temporal parietal hypometabolism that also involves the precuneus with sparing of the occipital lobes. This is a classic Alzheimer's disease case. And I'll come back to it later if I don't run too long. But it's really cool because you can look at this one image and you basically can make the diagnosis. You can try to learn atrophy patterns, and I can teach you that, and you can get efficient at it. But here, one image, often you're done. And so it's really a powerful way to recognize people who may have underlying Alzheimer's disease. Again, this is FTG, not amyloid. And so we wrote a review years ago that's kind of fun, but the other thing is I always think of myself as just somebody who's really good at guessing people's height or weights, except my talent is for dementia. And it helps to learn these atrophy patterns because they can help you when you start seeing discordant data, which we won't get into today. But if you learn to do this, you will get better than flipping a coin. But it really, when you add that FDG PET and the atrophy patterns, you get even better. And I think Jeff Petrella was really the first person to show this many years ago. And so it sort of eliminates the guessing game or the reluctance of radiologists to suggest diagnoses, because the PET is pretty clear there's something going on. And, it's not always easy, but a lot of times you'd be surprised how easy it is. And so I'll just skip this for the sake of time, but there are some limits to what I'm sort of teaching when I show atrophy patterns. So practical benefits. I'll go through this slide slowly. People argue about whether PET-MRI is a synergy or not, but there are a lot of benefits to patients that are sometimes underestimated. And so remember that particularly people who have epilepsy or dementia, they're not often coming to their appointments alone. And they're, unfortunately for us, they're coming to downtown Manhattan, which is a pain in the butt, right? So for them, it's actually really cool because they get to come in, they get the MR and the PET at the same time. And they also get a lower radiation dose. So because we're not using CT, the dose is in half already. And then because it takes longer to scan all those MR sequences, we use a longer list node. So we actually are down in the sort of 20% of the radiation exposure that a patient would get if they got a PET CT. And the advantage of this for epilepsy with children, I think, is obvious. Even in people who have dementia, they care about it, even though we all probably know that a single exposure is not a big deal. But particularly in this new era of dementia monitoring and anti-amyloid therapy, people may start getting multiple PETs. So it is helpful. And then, of course, especially in Manhattan, patients love that they get the best scan possible. So if we move on to refers, they like it again because the whole workup is done in a single day. The second line here could get me into trouble, but they also like it because they know that it's going to be read by somebody who cares about epilepsy or dementia and probably knows a thing or two about it. Then they also, particularly for epilepsy, can localize the finding, as I showed you in that first case. For radiologists, whether that's nuclear medicine, neuroradiology, or some other specialty, it's cool because you can actually look at the images together, and I'm going to show you more examples of that in a minute. We actually read it solo, and it's super fast to do it that way. Trying to do dual read can slow you down, but it's a much more efficient read. And then the other one that's really cool is that it makes us more confident. And so then I showed this earlier that we sometimes are a little reluctant to suggest dementias with MR or CT. But once you have the PET, a lot of people suddenly become heroes, right? Because it becomes a little bit more obvious what you're looking at. And then the other thing that's really neat to me, and I talked about this a little bit this morning, and I think this is useful for residents, even if you're not going into neuroradiology, but it changes the value of radiology for this patient population. So we suddenly become incredibly important for working up dementia patients. So the neurologist in Long Island who doesn't care about dementia, doesn't have time to evaluate it, trying to get their patients seen, loves PET-MRI because then they can call, Tom Wisniewski, the expert, and say, look, Tim said it's this, right? This is actually a very efficient way for them. Those patients are not volunteering that they have low frequency word finding. Right? Whereas the world expert in primary progressive aphasia does not want to see Alzheimer's. So they also prefer all of their patients to have had a study before they show up because it actually makes it much more efficient for them. And again, it makes us important, which I think is super cool. Anyway, this is a little bit of NYU peacock here, but I asked these referrers at our institution, these are all fairly well-known neurologists in the field, and they all have, I didn't pay them to say this, but they all, I think, have experienced that it's changed their practice. And again, this is just a little bit of NYU taunting here, but remember that NYU neurology neurosurgery has been ranked #1 for the last 3 years. So we have buy-in from a very good department on this value. And this is just an example of our volume. And we are a very neuro-focused departments or PET-MRI program. So the cardiac body is not particularly strong volume, but we have seen a steady increase in PET-MRI every single year. And this data is actually out of date. It says 2023 on the far right. But even in the last year, we've seen a 32% increase in volume. We are running out of scanner time. We basically are doing everything we can to maximize our camera time. Our volumes are going up anyway, like yours probably are, but that's more on the 10, 12%. So this is definitely a growth area within the Department of Radiology. Sometimes people say, oh, well, you're just stealing PET CT scans. And so this data is a little bit older. But what we see here is that PET-CT volume did go down a little bit in this sort of comparison of, I think it was 3-month periods in 2013 and 16. But the overall PET volume went up 300%. So again, I think this scanner really changed our practice pretty dramatically. It wasn't just shifting from PET-CT to PET-MRI. And again, the volume is pretty high. Again, this is more for administrators and chairs, but we are able to bill for it. And it turns out it's actually a little bit cheaper than doing a PET-CT and an MRI on separate days because of the multiple payer payment reduction act, et cetera. We are not having trouble sort of justifying, but these scanners are very expensive. So if you get one, you definitely want to be using it. And again, the reimbursement is there for you. So one of the problems that we had was we are oversubscribed. We don't have enough text. We don't have enough tracer. We're using every inkling of time. I think we have like 16 NIH grants on this. So those people always take too long. So we actually had to really make our scanner very fast. And a lot of other systems are, they do 2-hour PET-MRI scans. We're down to 40, 45 minutes, and I'm, running these Tortex ragged. So they call this the brain train. And I think with the second scanner, which is much more sensitive, we're going to be on the express train doing 20-minute slots. But we are using it pretty maximally. Sometimes we do as many as 15 cases in a day. And so we would go faster, except, and again, this is maybe just for a few people in the audience, we don't have enough uptake rooms. The patients are impaired. The dementia patients, unfortunately, sometimes they go to the bathroom before they get in the scanner to get rid of some of the radiation in their bladder, and they forget why they're there. And the techs have to go in and knock on the door and be like, "Hey, Tim, you're here for a scan." So they're not the most efficient people to get in and off the scanners, and the scanner itself is not the state-of-the-art Prisma in terms of the sequences that I can use. Nor is it the most sensitive FDG scanner for a PET detector. So I think I'm doing okay on time. So I'm going to show you a couple more cases, and you'll sort of see what I learned from these cases, and hopefully, again, you can think of ways that this might apply in other areas besides neuroradiology. And so this first case is a very old case, and I'll just give you a quick history of this. This is before we used that cool rainbow color that you've seen already. But when we first started, there was this question of whether PET-MRI attenuation correction was accurate enough to make clinical diagnoses. And so what we actually did with this first group of patients, and this patient was one of them, is we would do a PET-CT scanner near the Empire State Building. And then we'd put them in a cab and we would drive them over to the PET-MRI scanner with that same dose. And we would do a free PET-MRI we were trying to prove that it worked. And so this individual had a PET-CT first, but the PET data on both scans looked the same. And what you're seeing here, I think I put an arrow on it, it's a very similar pattern to what I showed you before. This dark red is an area of hypometabolism. This looks like Alzheimer's disease. And here's the PET-CT images that were obtained at the time at our cancer center. And I would say that, the scan between the MR and the CT were probably about 45 or 50 minutes apart. But I would assume that ride in the cab did not cause the stroke that was present at the time. So the CT, of course, shows nothing there. And I just challenge you, does anybody see the second finding that the CT does not recognize? So again, the cab drivers in New York are pretty reckless and whip your head around. But this patient also had probably amyloid angiopathy, which again is not seen with the CT scan. And then does anybody see the third finding? So you may, I don't think you can get this except retrospectively, but this patient actually had pretty bad inflammation associated with that amyloid angiopathy. So this is that old school, we used to call this amyloid angiopathy related inflammation. Nowadays we'd be worried they were on lecanemab and they had ARIA. But again, there were basically 3 findings that the PET-CT did not see for that patient. And 2 of those are actionable at the time of the scan. The MR did not see the dementia, right? So, or the dementia pattern. So I think they are mutually informative, and you could argue, and I think most people probably are thinking, well, we could have read them separately and combined them together. The problem that we see, and I think this has been our experience and why our volume has gone up, is that what you're doing when you read separately is you're asking the referrer to make sense of everything. And it's actually a lot easier to have somebody who knows dementia try to put the whole story together, because otherwise it's sort of disjointed and it doesn't really work. And I think also, again, reading them as a solo reader makes you a much stronger, better reader over time. Doesn't have to be a neuroradiologist, could be a nuclear medicine person as well. I don't want to get in trouble. But it really is so much more efficient to learn how to read both modalities as a single reader. Sometimes when we were doing dual reads, it would take a week to get the study finally signed, just because everybody is so busy. So here's a separate case. I'll just let you look at it for a minute. This is a case with word finding difficulty, very young. And if you look at it carefully enough, you might recognize this is probably something you have blown by if you've never seen it before. But there is asymmetric atrophy in the sort of temporal parietal junction on the left. This is a classic tell for primary progressive aphasia logopenic variant. Now, this isn't super specific, but when you see this with that history, we're definitely heading in that direction. And here's the FDG PET. Again, on the top row, we see left versus right. We see very severe blue and green in the same areas of atrophy. Other areas are relatively spared. This is a pretty great picture for a logopenic variant PPA. And these images are beautiful. And if you didn't know, the chair of radiology at Utah was really probably the first person to ever show the value and the way to do these surface maps. But again, I think it's very clear that there's an abnormality, and of course it makes sense with the clinical and the MR images. What's interesting about reading cases like this is it sort of changes the way that you read other images. So here I didn't have an FDG PET. And, after a while, like I mentioned in epilepsy, you start saying, gosh, every time I see this FDG abnormality, I see this. And so here again was a much more subtle version of asymmetric atrophy in that inferior parietal lobule and adjacent area. And again, people, even in my own section, are like, you're crazy. There's no way this is what this is. But then I finally, the history was headache or something at the time. But this patient actually was a speech pathologist who brought themselves in for word finding difficulty. And I may get a chance to show you some CT images where I've learned to read ED head CT the same way. And I often recognize dementias. It's because I kept getting this FDG feedback. And as a reader, it's just so cool to learn how these subtle findings sort of change the way that you read. And to be honest, the same thing happens for people who come from a FDG or a nuclear medicine background. Sometimes the MR starts to change the way they read the FDG PET, or the way that I keep telling them, like, oh, this is really important. Oh, I never thought that was, you look at the thalamus? Yes, I look at the thalamus. But it's been a really, really great experience to learn like that. And the other thing that we have done is we love those beautiful rainbow images and the surface maps. We saw the value in reading quickly. So the other thing that we started doing was we started playing with cinematic rendering. And we took an MP-RAGE with the Siemens software, and you could see, for example, here again, maybe a different way to improve our yield of detecting inferior parietal lobule atrophy pattern associated with PPA. And to be honest, my experience is that the textbook cases are very obvious. And I think part of it is that I'm not that used to looking at cinematic rendering, but I think it's more valuable in teaching people to recognize atrophy patterns with standard imaging. But we actually sometimes, we haven't fully done it, but we send these to PACS, and the referrers and the patients actually love it. And they're like MRAs, so you can rotate them, and it's a lot of fun. So I'll skip the details here, but what we did find was that the Siemens software didn't work as well as we liked for stripping the dura. I know somebody in here is interested in 3D rendering, et cetera. Getting the dura off is really hard. So we actually created our own little secret sauce here. Here, just another example, two dementias. This is a different PPA logopenic variant on the bottom row, but the top row is an FTD case. And again, if you're trying to teach residents what knife blade atrophy looks like, this is kind of a cool way of doing it. I don't know whether this would, save us when we're reading these studies on a routine basis. But you can see, again, the differences between a PPA variant atrophy pattern. The bottom two, again, you see that opening up of the sulci compared to the contralateral side. We see this pretty severe atrophy in the sort of posterior hemispheres. Again, we've just been having fun with this. I still am not convinced that it's useful in every single case, but it is cool. And I do think it has a teaching utility. So again, it changes the way you read studies and it changes what you do. This last sort of cluster here, this is 2 different cases. And the surface maps for epilepsy, to be honest, are not that helpful. And that I always tell my trainees that if you try to read epilepsy based on surface PET, you are in a big trouble. And there's a reason, because there's actually 4 areas that you don't see on the surface maps. So you don't see the hippocampus, you don't see the insula, you don't see the basal ganglia or thalamus, and you also don't see the occipital temporal area that's covered up by the cerebellum. So what we do when we read FDG for epilepsy is we really focus on, is there a focal subtle abnormality somewhere here? And most of the time it's still going to be a segmentation artifact, but if we see it, we make sure that we pursue it. And so I had actually read the MR on this case already, and I thought it was negative. And then I said, wow, what's up there in that right orbitofrontal area? And I just tell you quickly as an aside, I love orbitofrontal seizures because they confuse the epileptologist to no end. The EEG is super confusing. So I always love sitting there and watching them, spend 20 minutes arguing about where the seizure origins. And I'm just sitting there just like licking my lips, like, I got you. But when I have a PET finding. So I went back and looked at the 2D images as well, and it was a real finding. It wasn't just a segmentation of the 3D rendering. And when I went back and looked at the MR, I was kind of embarrassed. I didn't tell anyone else except you guys just now. But there actually is gray-white blurring there that I just didn't catch, just missed it. And this is a way of redirecting an MR search, okay? And to be honest, I think my opinion, and I'll show you one more example that's the opposite, is that if these were read separately, this would have never been caught. And it really is learning how to read these as a one case that really allows you to catch some subtle epilepsy findings. Here's another surface map. The scale's a little high, but basically looks completely normal. And again, I think I'm on time, but for the trainees in the room, remember that when you are injected with FDG PET, you're supposed to keep your eyes open, but you're in a dark room, you're bored out of your mind. And so certain areas are more FDG avid than others. It's sort of, we learned about default mode network basically from PET. And so these patients ideally are kind of daydreaming, and you see these sort of changes. The frontal lobes tend to be very FDG avid, but this is essentially a normal looking study. And this is the classic, just like in neuroradiology, people who are working up epilepsy with PET often just focus on the temporal lobes and forget about everything else. And I'm the person who did it here, but this is a totally normal looking medial temporal lobes. Remember, you're bored, it's a dark room, you're not learning anything. So the hippocampus are actually a little bit hypometabolic compared to the other areas. And so then I looked at the MR, and this is actually very similar to that first case I showed you. But essentially, again, I saw this sort of telltale blurring of the gray-white in the mesial area. I knew that this was a child. I think they were like 8 or 10 years old. They had nocturnal seizures. I think they might have even had bicycle kicking motion. I knew that the SMA was where I should focus my search. And so when I went back and looked at the FDG PET again, there it was. So I don't know if I put an arrow on it, but if you look at that middle image, you really see this very subtle FDG abnormality corresponding perfectly to the MR abnormality. I read the PET, I would have never caught that if I had not gone back after I saw the MR finding. So it really, my point in these 2 epilepsy cases is these heightened reads, I think, allow us to see things that we would have never caught in the past. And it helps to have somebody who knows how to read both of them simultaneously. So the last few minutes, I'm just going to show you a couple what I think are really cool sort of applications at NYU that are, some of this is not FDA approved. I don't have any vested interest in it, et cetera, except the research. But some of the things that I think are really going to dramatically improve the quality of PET-MRI in the near future. So this slide I can't really explain to you very well. This is the reference for you, but essentially what I want you to understand is the black and white image here is conceptually, it's a MP rage. And you can use the gray-white contrast of the MP rage to sort of constrain how you reconstruct the PET. And so you can actually make that PET image, we always call it unclear medicine. And you can actually make the PET image look like a T2 weighted image. And of course, if you're trying to train radiologists to read these, it's just like, oh, this is the T3 sequence, right? So I'm going to show you an example. When the PhDs came to me and they said, oh, we've got this new thing, it's really cool. I'm like, oh, this is going to be some stupid thing. It's not going to work. And so I gave them a very easy case. And this case, hopefully everybody can see the finding, but is pretty clearly left temporal lobe hypometabolism. It's an epilepsy case. I don't think it's very hard to read this part. But when we did the joint reconstruction, and I'll tell you, you can see hopefully the difference in detail. We were doing this as part of a radar study. So part of what we did was we actually blurred the images a little bit because otherwise the nuclear medicine radars didn't like it. So actually can be sharper than this. I'm good friends with our section, so even though I know you're recording me, they won't get mad at me. But it was incredibly humbling. Everything about PET-MRI is sort of humbling, but it makes you such a better clinician, I think. But what I realized is, you can see the arrow, was that this seizure actually involved the insula. And I had completely missed it 3 years prior when I read the original study in real time. And it was kind of, again, very embarrassing, but I was like, oh my God, this actually might be dramatically helpful. And some of you that read epilepsy may know that insular seizures are the kryptonite of epilepsy. It's about 10% of all seizure foci. It's probably one of the leading causes of failed epilepsy surgery. It often looks like a temporal lobe epilepsy. And to be honest, you're lucky if there's a cavernoma or a lesion there. Most of the time, they're MR negative. And so this was really a pretty dramatic early example that I saw. So again, I'll try to stay on time. I think I'm doing okay. But we did a radar study where we showed them cases of different complexity. And here, just a very easy example, just to orient you. The standard reconstruction on the left, the new reconstruction on the right, very classic right medial temporal lobe hypometabolism. 3 out of 3 got it right on both examples. So here's the second case. I'll just let you look at it for a minute. And I would just tell you, as we all know in case conference, especially if you're not the one getting called on, I am laying these out for you, right? So there's an abnormality, there's probably a trick here, but it's not so easy when you're scrolling through these images. And so they all, I think, got the medial temporal lobe was hypometabolic, but they didn't see the second focus in the parietal area. And again, just like neuroradiologists, they all get fixated, nuclear medicine readers, standard teaching, they all get fixated on the medial temporal lobes. And what I always tell people, again, this is a bit of an aside, but when you read a PET, like this image on the left, and you see subtle hypometabolism in the hippocampus, you have not necessarily found the seizure focus. You have found the correct side, but you have not found the focus. You need to keep looking. And so again, what we see here is that with standard reconstruction, only one of the 3 raters caught the second focus, but with joint recon, they all 3 got it. Here's probably the hardest case, and I'll just let you look at it for a minute. So what we see here is sort of a frontoparietal opercular lesion, pretty subtle. And to be honest, there's a hypometabolic area here in normal individuals that's nearby. So this is a really hard case. Only one of the 3 raters got it, and only with the joint recon. And so again, just for time, I'll go quickly, but these are our 3 raters. The number 1 rater was the most experienced in neuro. You can see that it didn't degrade their reads, but the second 2 readers both got a lot better. And so I should write this up, but the p-value was a little high for the group. But basically what we saw was that in less experienced users, the joint reconstruction really helped increase the detection of potential epileptogenic lesions. So just another quick example, I already showed you one of these, but particularly for the insula, in a standard PET, the putamen is crazy high and it blurs out the insula. So it's actually very hard to see the insula with standard PET. But here we can actually see these asymmetries. And so David Ola, one of my future fellows, and I are writing this up now, but we find that joint reconstruction really helps with recognition of insular foci. The one on the right, you might actually say, oh, that's just the way you've angled the view or whatever. But the other thing that joint recon does is actually shows you subtle deep gray nuclei asymmetries as well. So hopefully you can appreciate that the left anterior nucleus is also out ipsilateral to that insular finding. And so when I see that, I know I'm not overcalling it, and I've probably found the correct focus. One of the other cool things about the joint recon is, like everything else these days, you can tell a neural network to do a better job with it. And so when we were doing it with the math, the Ballister reconstruction was taking 3 hours. Once the CNN learned how to do it, it took about 20 seconds, but definitely under 5 minutes. And you can see that it gives relatively similar results if you compare the second and say the third or fourth images. The other thing that's interesting is once you put a neural network on it, it doesn't need as much data. So historically with PET, we use 10 or 20 minutes of list mode data. The CNN doesn't need all that data. And so we could even use just 1 minute of data. And so again, ideally for FDG PET-MRI, we've got a patient that's like this, but sometimes they come in like this, they're dancing all over the place, and we don't get a long time scan of uptake. And so we really were looking for ways to potentially reduce our need for these long uptake times. Now, one of the things that you might do that for is to reduce the dose. And what I would tell you, even though I know I'm being recorded, is that for most patients, this dose doesn't matter. But I have, 5 different technologists, 4 of whom are women in their 20s, working with these patients, leaning over them all day, and we're running 15 cases a day. So for me, to be honest, my real concern with dose is actually my staff. But you can also reduce the camera time, which makes chairs very happy. And if you have patients who move, you may still be able to salvage the data. And so here's just an example. This is a retrospective study that we're just about to submit, looking at an early onset AD patient with classic findings of AD that I've described to you in 2 other cases. And on the far left is kind of our standard PET. And here we've dropped the dose on the far right by 95%. And we actually are already down a little bit higher than this dose that I have in red here. But I think particularly with the second generation scanner, we may be getting down into 1 millicurie, half a millicurie doses. I often tell the chair and the Siemens people that we're going to be doing homeopathic PET MRI. It introduces a lot of interesting possibilities, because when you do doses that low, you could inject a patient and have them sit in this room with everyone else, and it wouldn't matter. You don't necessarily need uptake rooms anymore. So it's a really, we obviously do it within the radiation safety rules, but there are some really interesting possibilities. And I got a chance to show Dr. Minashima this, but this is the sort of follow-up to doing surface-based reconstruction. So those cool surfaces I showed you before, one of the limitations of those is that all of us have different brain sizes and shapes, and sometimes the algorithm doesn't work. And so the segmentation will give you these weird caps, and it basically becomes worthless. And so what we did was we took that joint recon, which is sort of 1 millimeter resolution quality PET, and we basically stripped the head off, if you will, which is much easier with PET because the scalp doesn't generally take up FDG unless they have a very high glucose level. And we basically created a VRT of the PET data. So what's different compared to a surface is that what you're about to see is actually the patient's brain anatomy. And I hope it's going to play. It always catches. So you can basically generate an image like this. And again, just like we were talking about earlier with the cinematic rendering, you can put this in packs as like an MRA where you rotate it. We figured out how to open it up so we can see the mesial surfaces as well. We're almost got it working for we can get into the insula. So we're really excited about this. And I was telling Dr. Minashima before that these color maps, when we first started doing them, Kent, who's my great friend from nuclear medicine, he's like, I don't know if we should send these to PACS. And, there's some artifacts. I'm like, Kent, this is advertising. These are incredible. And I think this actually will probably be the same way, that the referrers and patients and their families will really love being able to see this. It's very intuitive to read something like that. It also turns out to be really helpful for reading amyloid. So when you read amyloid, you take the online course, and all the cases they show you are like straight out of an ABR exam. They're the easiest cases in the world. And then the next day you get real life thrown at you. And amyloid is actually not always so easy to read. But with a joint reconstruction, it actually becomes a lot easier to recognize whether there's amyloid in the cortex or just in the adjacent white matter. And I'll just show you, I showed this morning, but this is just, again, an example of a positive case compared to a normal case. So we find that readers are particularly more confident and more accurate. but particularly at lower levels of amyloid with the joint reconstruction, we tend to recognize it. So again, most of you probably don't know the centiloid scale, but we often have readers who will pick up amyloid positivity with this joint reconstruction where the centiloid is 12 or 15. So we are actually able to see the lower range a little bit better. That, of course, hasn't been published yet. But again, particularly lower levels, we recognize it. So this is the last kind of cool thing. But what we're seeing here is somebody sneezing on a PET scan. And remember that when we do a PET image, we're requiring 10 or 20 minutes of list mode data. And then we take all that data and we make one image. But you can actually break it up. So what you're seeing here are just 100 millisecond counts. So this is 2 seconds broken up into 20 images where the patient sneezed. And so, you know, I would get really angry if someone asked me to read this quality of PET, even though this is sort of a history lesson from 1978. But what's interesting about this is we can, math and the CNNs, et cetera, can, and again, I know I'm doing a hand waving here, but they can determine the center of mass of the image, even if it's 100 milliseconds of data. And then they can basically just take 2 images that are next to each other and realign them. So they can basically realign all that list mode data. And so what they end up with is something, this is sort of the other concept. Here, these are 2 seconds of data in the sagittal orientation, and that sneeze is on the second row, second image. If there's motion during whatever the window you use is, like here it's 2 seconds, you can just throw that data out and then just use all the other data. And so what it turns out to be extremely helpful for is dementia patients who don't like to hold still. And so I talked about earlier about rapid GRE and SWI, but this is my other secret weapon. What we have here, hopefully everybody can see the top left image for the people online, was a study that basically I had to call the referrer and I said, look, they couldn't hold still. I can't read this. And I said, look, I can try this new fancy thing, but it's not FDA approved. But basically what you see is that we have the motion graphed here in yellow, blue, and red. But once we corrected the motion, it became a diagnostic study. And I'll show you the surfaces in a second. Here, the one limitation of this method that we see is that the data where there's motion during an individual time frame gets thrown out. So this patient was kind of doing a Stevie Wonder, and there was a lot of motion. That meant that there were a lot of data. We threw out basically 40% of the data. But if it's just I always describe it as the Stevie Wonder versus the Terminator, right? So Terminator just, I'll be back. They just, 6 minutes into the scan, they turn their head. Those are very easy to fix. This is a little bit harder, but again, we were able to recognize a classic AD-like pattern in this patient once we did the motion correction. And so here, again, this slide may not explain itself well enough, but with amyloid, I'm particularly nervous about motion. Remember that when you do an amyloid PET, the white matter is going to, everyone in this room would stain intensely positive on an amyloid PET scan in the white matter. So if the white matter is super positive and they're moving, you start to bleed into the adjacent cortex. So if you have motion, you can actually get people that are erroneously read as positive, or the centiloid scale is high. And so again, the motion correction seems to clean these data up very well. And so just quickly in the last 5 minutes, hopefully I've convinced you of how fun this experience has been for me. And this is just another story, but when I was a UCSF fellow or resident, I had to fly to Louisville, as I'll mention in a minute. And, I was like, oh, I'll do the authorized user thing. And, the guy showed me a box and I was like, oh, you got to clean it this way and, whatever. And I barely passed. And I thought, there's no way I'll ever be doing this. But 2 or 3 years ago, we actually had a pretty bad labor shortage. And so for about 6 weeks, the neuroradiologist, looking at you now, was one of the PET techs. And so I basically had them set up a reading room for me right next to the uptake rooms. And I would basically just run in there and do the injection. And then I would come back and read as fast as I could. And, 30 minutes later, I'd run in and do another injection. So it was really kind of a neat experience. I'll come back to it here in the next slide, but I would just tell the residents and fellows, you really never know where you're going to end up a decade later. I really didn't think that I was going to be that person. PET-MRI, to read this as a solo reader, you have to know some things that we as a radiology society don't do a particularly good job of educating people about. So neuroanatomy, dementia, epilepsy, artifacts, FTG, amyloid, surface visualization, these are not things that most people coming out of residency or fellowship learn well. And I've told this joke before, but when I got to NYU, I read 3 FTG PETs and 2 of them were on the 7th floor of this hotel room. And I think I failed one of them. I got a 59 on one of them. So I had not been trained when I got there. You guys have been spared this horrible hotel. But we started with a dual read, but it wasn't particularly efficient. But we're in a situation where over time I got good enough, and Kent, who's the section chief for nuclear medicine, was comfortable with me reading them on my own. He's still involved when I have questions, or I always show him great cases. I don't read the PET-CT, but I actually now, it's kind of gone full circle to where I now often help nuclear medicine specialists who are not interested in neuro particularly read better. And we got a lot of feedback. And at NYU, again, a very unique situation. We have 5 neuroradiologists who read almost every single PET-MRI for the brain. And I know that's an unusual place. I think that all of us have a responsibility to teach people more about PET, because PET is extremely useful, and I think it's going to grow. And again, what I always tell the fellows who roll their eyes when I'm teaching them about PET-MRI is I say, look at me. No one trained me to do this. One of the things you can learn by watching this is just how a middle-aged man learns some totally new thing. I was like, whatever, you're about to graduate and you think you know everything, but in 5 years, there's going to be some new MR sequence that none of us knew anything about in 2024. And it may be revolutionary. And so I always tell the fellows that one of the things you're learning is how to learn new things once you finish your training. And so this is just a quick example, and I'll sort of finish up here. We do dotatate, and we're starting to do a lot more of it, but there are I showed you a lot of epilepsy and dementia, but there are other things coming. And again, I'm not a University of Utah head and neck reader, but I can usually handle a meningioma of the skull base. This was a recurrent meningioma. I saw 3 of the meningiomas before I turned the dotatate on, but I did not really appreciate the one in the cavernous sinus here. And I certainly didn't see this. I know it looks very obvious, but this just looked like normal tentorium, and it's just lighting up like crazy. And so there were actually 3 other meningioma deposits in this patient that I did not see with the MR. And I think that this is just another example of what, in my mind, PET-MRI is just going to keep clawing away new parts of radiology. And I think FET, which is a tyrosine analog, will probably become very important for tumor recurrence versus radiation in the next year or 2. It's already used in Germany quite frequently. I don't think it's a cure, but I think it will also take away PET imaging or standard MR for that patient paradigm. And so just quickly, if you guys will tolerate, I do think that neuroradiology is changing. And I think that PET may not solve all these problems, but if I was to grade how well we're doing, we certainly do an amazing job at stroke. But psychiatry, we are worthless, right? Once a year, you see some really good psychiatry finding, but it's pretty rare. And I think that PET, particularly with new tracer development, has the potential to make us much more relevant. And some of the things I'm showing you here are extremely common. So we could certainly do a better job. And again, I'll go through it quickly, but as a neuroradiologist, when was the last time you confidently said you knew you were looking at Parkinson's disease? Or, the people who read epilepsy in the room, how often do you really find the true finding? So I think PET-MRI really has a lot of potential there. I'll finish with this slide. Our experience has been different, and we are very neuroradiology dominant for our PET. They're all being read almost exclusively by neuroradiologists. We have historically always been very aggressive about using new technology, and we emphasize throughput, and of course we have all these grants on the scanner. Again, we are a Siemens site. The first true second generation scanner is about to come out, and we are actually ordering 3 of them. And our intention, again, like I mentioned earlier, is very low doses, very short protocols. We're going to be doing joint recon and motion on everybody. We'll probably be using an atlas with AI. for diagnosis and recognition. And again, my intention is to start stealing more and more of neuroradiology. We sometimes joke that at NYU there should be a PET-MRI neuro section. Right now, it'd just be 2 or 3 people, but it's becoming a more dominant part of our practice. And again, I will just show this quick slide, but this is coming. This is the amyloid PET volume for us, and it was a trickle. And then we got these approvals, and we went from essentially reading a couple a year to 10 a month to 40 a month to 40 a week. I think we're now getting close to 80 a week. It's coming. And to be honest, nuclear medicine, there's just not enough people to read this number of studies. So again, I think as a trainee, you should try to learn a lot about PET, because you may end up like me and be thrown into it at some point in the future. So I'll skip these last 2 slides, but I just want to put my acknowledgement slide up there. And again, thanks for inviting me to speak. Thank you all for your attention. It's always great when the audience looks like they're still awake at the end of the talk. And I appreciate it. It's really, and I was telling someone recently, but it really is part of the talk is the experience of interacting with everyone. And I really appreciate everybody paying attention. Thank you. Any questions? Yeah.
Questions?
Thank you. That was fantastic. Big example with the convoluted neural net. To a dosing at the Empire State Building facility, and then next day imaging.
I think 24 hours may be too long.
Afternoon to morning.
Afternoon to morning would work for sure. Because we, the half-life, just for the audience, for FTG is 110 minutes. So that means that basically at 2 hours, you have half the dose left. And so I'll give you a little bit of a long answer. It's okay. We do dual phase FTG PET for radiation versus recurrence, because it's FDA approved and we can get, approval to do it. And so what we do there for brain tumor patients is they get a standard FTG PET like 60 minutes after injection. And then we say, hey, go have lunch, do whatever you want, walk around, come back 4 or 5 hours later. And when we first started doing this, my technologists were like, oh, there's not going to be any dose left. And that, to be honest, it was still just red hot. And so I think you could probably easily get to 8 or 10 hours. And I think Jason, I'm blanking on his name, is it Coleman? The section chief at Yale has published a few papers on dual phase FTG for brain tumors, where he's waited sometimes 10 or 12 hours. He was at one of the UT cancer centers, and I assume they went off and had appointments or whatever. We try to discourage that, we give them the same instructions as they go home normally. Like, we don't want them hanging out with small children in between the 2 scans. But it's not a lot of dose once the patients have frankly peed, and then it's 2 hours out. They're even 3 feet away. You're hardly going to get exposed to anything. But there's plenty left in that. Any other questions, please?
I was just wondering what other applications you've been using the PET-MR for. You mentioned that, talked about dementia and then tumor versus recurrence, but
Yeah.
anything else with neuro or non-neuro?
So I'm very epilepsy. Dementia is overwhelming us, to be honest, but we do a lot of epilepsy and dementia. We actually do a lot with autoimmune encephalitis. And what you realize with PET-MRI with those patients is that a lot of patients who have that disease or that syndrome, if you will, they don't go into the ED with frank new psychiatric disturbance. But like, some people have a very smoldering form of it. And, it's controversial, but this post-treatment Lyme disease syndrome, we actually see people, I was very skeptical. And then sometimes the PET is very obviously abnormal. What it means, who knows? But we also see long-haul COVID patients will often have FTG abnormalities. But other than that, FTG, we've been trying to build it for CNS lupus, which about 50% of the time the MR is negative. It works for temporal arteritis. It works for athro. It works for TBI, but it's not specific. There's some risk to even doing it. F-DOPA is kind of the one I'm trying to build right now for movement disorders, but also maybe for tumors. Trying to think, dotatate is, of course, taking off. Those are kind of the main ones, I think. We're starting to do a little bit of tau, but not a lot clinically.
And you have a 3T MR, is that right?
It's I think all the commercially available PET-MRIs are 3T. Harvard is actually trying to build a 7T version.
And are you all doing any vessel imaging for vasculitis? And
So
you mentioned that.
I hope that's not being recorded, but NYU has never been super strong at BWI, but Evan Stein, who joined our group, is building it. And I keep telling Evan, let's start doing FTG as well.
Yeah, we've been seeing a lot of patients that end up getting both just because they're complicated, and then we have to kind of go back and review it in conference and that sort of thing.
Yeah, I think the second generation will be better because this first scanner, it does have a 32 channel coil, and it actually looks really great. But the standard MR and the hardware, for vessel wall imaging, you really like to have really high quality, like T1 space. I think the second generation scanner, maybe the GE or the United Imaging one has better scans, but I would wait for Siemens. I probably want to wait until we have the second gen just to get the BWI MR component right. But I keep telling Evan, like, let's just do FTG right then. It's a very low dose, and you don't even need a lot, and you'll see it straight away. There are other groups. Zahi Fahad at Mount Sinai has published a lot on FTG. I think more for athro, and he's really into lifestyle. But anyway, I think there's kind of limitless applications, really. Yeah.
Kind of a follow-up question. Do you feel that on the first generation, the head and neck coil and the body coils are good enough for metastatic head and neck disease, or for like metastatic VO? We happen to have a large like FDA.
Our body people don't like this scanner. Some places are using it. But for prostate, we do some prostate cases, but not a ton. And again, I think the second generation scanner, again, we're a Siemens site. I know their scanner well. I think a lot of what they have purposely done is try to make that second generation better for body. But we don't do a ton of it, if that's what you're asking. Head and neck, tell you a funny story. Do you know Elchin Zan? Elchin came and read PET, and I sort of got the LISMO data moved down about 3 inches after Elchin showed up. So I always blamed her for this, but I would always purposely look at the LISMO data because I was terrified I was going to miss, the tumor in the suprahyaloid neck. It seems to do pretty well, but we haven't done a lot of head and neck there. Our referrers are very into CT, I think still, but I also haven't had a local champion. I think it really helps to have a champion for head and neck. And I was the second baseman of head and neck imaging before Mari kicked me off the team. So anyway, other questions?
Awesome talk. I think you made a really great point that, before I was very skeptical of PET-MR versus PET and MRI, all the information together in a different independent acquisitions, but the same person interpreting with MRI and FDG PET makes a huge differences.
Oh,
because you're basically looking at the PET only versus the MRI only, but we never had a same person to interrogate both information into complex, like cohesive report in a way that.
Yeah. And I was talking to Dr. Minashima earlier about this, and there's some turf politics involved in it, because to be honest, it's easier for a neuroradiologist to be that person. And I don't say that because I think it should be exclusive, but it's much easier for a neuroradiologist, in my experience, to learn PET than the other way around, because MR is hard, right? But there's a huge advantage to having one person read it.
Yes.
It's so much more efficient, but it also it changes the way you read forever.
Absolutely.
It's a neat experience. What we see with fellows is that the first half of the year, they get really good at dementia. And I don't even bother really trying to teach them epilepsy too much, because I'm like, you're just not ready. And, they just think I'm crazy. They're like, oh, I can't believe you called this. And then in the second half of the year, their eyes open when they see all these subtle findings, and they learn epilepsy in a way that they would never learn just reading MR.
Yeah.
And, being a single reader also is just a really cool experience. It definitely makes people better readers.
Yes, Absolutely.
Yeah.
So that's a huge point of epilepsy and dementia.
Yeah.
I think in terms of like this 3D surface projection, it's not just a surface projection, but statistical mapping.
Yeah.
So it's a G map is really allow them to really show
Yeah.
what's compared to normal. Because when you look at the brain MR, brain PET, FDG PET scan, it's a certain areas of more higher metabolic activity like occipital lobe,
Yeah.
primary visual cortex. So adjusting that for statistical mapping makes so much easier to actually jump into the diagnosis specifically.
Yeah, no, I didn't mention it, but the other issue with the statistical mapping, I think for CT is amazing for CT. But the problem with PET-MRI is that the attenuation correction is different. And so like MEM, the software that we use, the database is based on PET-CT. And so I personally don't really, I showed you I confess, I did show one example, but I actually don't really look at it because I'm like, it's not valid for PET-MRI. And I keep trying to convince Siemens to give me a lot of money to create a database for them. But the other thing is I think the PET-CT data is better, but the MEM database, for example, it's only like 45 patients and it's between the ages of 20 and 80. And so like I've asked them, I'm like, how many of these people are 60 to 80, which is what I'm supposed to be using? And they're like, oh, 20 something, I'm like, and I was like, how do you know they didn't have part or late or they just, so for us, the MEM database, I don't really trust it. I love MEM otherwise. And then the other thing that we have problems with that I'll just mention, but again, I think for PET-CT can be useful. A lot of patients take sedation. And if you don't watch it, they'll take it before you inject them with FDG. And so we've sort of beaten it out of our referrers. And I said, no, don't give it to them straight away. Tell them not to take it till we tell them to take it. And so what we try to do is we acknowledge it and we make sure they're comfortable. And we say, look, if you take it right now, it's going to wear off before you even get in the magnet. And so what we do is we have 20 or 25 minutes in, we let them take it.
Nice.
So that FDG has sloshed around for a good, perfusion probably went through 20 times. But if they take sedation or they're on an anti-seizure med, which they're almost all on, the Z-scores are worthless anyway because everything is down. It's just like they had a couple martinis before they got an FDG injection. So the Z-scores, I think they have value. And I'm a little bit outspoken in a way about it, but it's the same thing with volumetrics and like I think they're useful tools, but I think we just have to be careful to really understand how they're used and when they have limits. But PET-MRI, there's no database that exists.
Right. Not enough data to create it.
Yeah.
Statistical mapping. It's great. Awesome.
Okay. Well, thank you so much. What? Oh, and they're like, yeah, we're going to just drop me off. Yeah. I'll talk to you.
What happened?
What's that? They like. Sort of.
No?
Yeah, sort of.
And we couldn't get out because so you needed at the point. You backed off. So you're okay. So we'll do our walk up there. We'll be like, yeah.
I'm out right now. It's definitely.
I don't know what.
We'll do some of that stuff.
Like,
I should have let you stop.
Yeah, but the concept of
One day was like holiday, which
the brain is
ski putter. And also meant the next morning, which was a sunny, bluebird day, was. Yeah, thank you so much.
Yeah.
Come up in a surface projection. That was 1995, 30 years ago.
Yeah.
So it came a long way, but I agree 100% that PET diagnosis is so much easier. Just looking at images. I don't even scroll the source images.
Yeah,
I
you just like,
should,
oh,
but
it's this.
it's like, oh,
Next
that's
case.
that's a DLD. It's so easier.
We've actually made epilepsy painful though, because now you have to really
It
look for
is
the
a
small
painful now
findings.
because you have to.
Thank you, Rory. You're welcome.
Yeah.
Really appreciate your time. Your planning looks like it worked really well. So thank you. Is it okay if I grab one or two to just bring to the reading room? Because some of our help. Can I bring two? Is that okay?
Yeah, to be honest, I don't really emphasize the quantity.
I'll bring it
I
to
do, but I don't, I used to try so hard and now I'm just like,
What? Technology, it was so much more like a boss, and I'm
Yeah.
actually doing a PET feed for the head transfer because you can make some beautiful things.
Yeah.
And then the control really doesn't then so it's like a book us to knowing that some of the anatomies and the pathology to interpret it.
yeah,
So that's
I keep trying to get a champion. I think if I had somebody at NYU who was into it,
yeah.
we would be doing a ton of neck.
Actually, Rick Wiggin doesn't need it.
Who?
So Rick Wiggin.
Oh,
But
and people.
in that I mean,
It's-
it's
yeah. I think dotatate is really the thing. Nowadays with dotatate, I start with the dotatate. I'm like, well, let me just see where all the meningioma actually are.
Yeah.
So I know which ones to get.
All the meningioma need to dotate or the specific typical aggressive meningioma because
Yeah,
I mean, in New York, anybody just throw the money into anything. But
Yeah.
even that kind of concept of like
we,
every single meningioma.
yeah, no, we're not
you
doing
know,
it for everybody, but
Yeah.
I think we're heading for, they come out of the surgery with a
Mhm.
grade 2 or higher,
higher.
or there's a recurrence.
Recurrence.
Yeah, the recurrent one.
That's kind of where I want to
Yeah,
get
I
us
think so.
to, but I think that's what Yana is doing at Cornell.
Yeah.
That's kind of her.
I think we just need to have a more like.
There's
a
too many. You don't
appropriate
want to be,
indication.
you know.
You don't want to have a little small like a cortical
Yeah.
based meningioma.
And we're using it only